All right, I think we're ready to get started. Thanks so much, everyone, for joining us today. This is the Essential Substance Abuse Skills webinar series, and I'm Kate Trams. Today we have our own Sean Bear speaking on clinical evaluation assessment. This training series is brought to you by the National American Indian and Alaska Native Addiction Technology Transfer Center. We are part of the ATTC network, which also includes 10 regional centers and a network coordinating office. To learn more, please visit our website. This series is designed to be a broad overview to assist in preparing for written alcohol and drugs certification exams, or to enhance existing knowledge and to improve overall competence and treatment outcomes. Please be aware that this series is not meant to stand alone, and previous education and training is necessary in order to pass alcohol and drug certification exams. Our center is an ADAC certified educational provider, and CEUs are available on request for a $15 fee. A request form is available for download in the Files pod, and we will also be sending this form out in a follow-up email to all who attended. Immediately following today's webinar, you will be redirected to our GIPR evaluation. This survey asks about your satisfaction with the event and will take less than 10 minutes to complete. We thank you in advance for helping us to improve our programs. You will be muted for the duration of this webinar, so if you have questions about the presentation or about the Adobe Connect system, please use the Q&A pod by typing them in the fields at the bottom. We also have the chat pod, which is not anonymous. So if you want to put thoughts out there during the presentation and open up some discussion, that's welcome to do, and that chat pod is meant for that purpose, and everyone can see that and participate. And then the Q&A pod is something where you can be anonymous. If you don't want people to see your name, you can submit a question there, and we will address that at a certain point in the presentation, probably a couple different times. Today's speaker is Sean Bear. He has been working with the National American Indian and Alaska Native Technology Transfer Center for, I believe, 4 years now, and he is an Army veteran of 9 years, discharged from the 82nd Airborne. His passion is to assist people in overcoming their substance use issues as well as other issues, and to return to the spiritual ways of their ancestors. So we're grateful to have Sean here sharing that passion with us today and teaching us about some of his experience in working in substance use treatment. And with that, I'm going to pass it over to him for the clinical evaluation assessment. Thanks so much.
I have the notes. Okay, hello all. Again, my name is Sean Bear. I'm from the Meskwaki tribe in Tama, Iowa. Okay, let us get started. So here are the goals. The clinical evaluation for assessment is, at the end you should be able to define assessment process, identify assessment instruments, define the DSM-5 criteria for substance abuse and dependence, specifiers and multi-axial assessment, describe ASAM levels of care and diagnostic and dimensional criteria. Okay, so let me see. Okay, so the purpose of screening is to determine whether an individual needs an assessment. The purpose of assessment is to gather the detailed information needed to develop the treatment plan that meets the individual needs. So remember, just because somebody comes into treatment, when they do the screening process, it doesn't necessarily mean that they will also move on to treatment. Okay, the screening, problem assessment, and the personal assessment. So screening is a process of evaluating the possible presence of a particular problem. This outcome is normally gathered by a simple yes or no during the screening process. The assessment, on the other hand, is a process of defining that issue, determining a diagnosis, developing a specific recommendations, and an individualized treatment plan to address the issues or diagnosis. You'll see here that from the beginning, when you first see a client, through the screening process, through assessment, and later on into treatment, the amount of information and time needed accumulates over time. So you'll see that through screening, problem assessment, personal assessment, then it can go further into treatment, aftercare. The cost for the program goes up while also gathering more information. Okay, so information is sought along 3 dimensions. So we're going to be looking at the use of alcohol and or drugs, signs and symptoms of alcohol and or drug use, and consequences of alcohol and drug use. So looking at an initial step is to ensure that the client meets the level of care by gathering the client's medical history, such as previous treatments, current therapy, or prior use. This, remember to include like medical, behavioral, social, financial. We don't want necessarily the client to not understand the financial costs when they finish treatment. So the use, you want to figure out what they're using, the amount, the length of time, age of onset, and how often. Signs and symptoms, whether they've had blackouts, brownouts, meeting social or familial or work obligations, the consequences, looking at whether they have arguments, employment loss, cultural loss, spiritual loss, education loss, and I put like education and employment because if there's a problem with use, then they might not be able to fulfill those obligations for education to finish maybe college or something like that. So this helps in establishing the severity to whether their identified problem will be either mild, moderate, or severe. So determine appropriate level of care. Okay, so then we get into the contents of the screening. So whether it's a brief process that answers 2 questions really, is whether an alcohol or drug use is present. If so, whether it is likely to require brief intervention or specialized treatment. Brief intervention for youth might be in education, classes, something that has to do with drugs or alcohol, maybe their behaviors or something like that. Okay, so examines the content of the problem assessment, examines problems attributable to alcohol and or drug consumption. 3 techniques are available here, and we'll talk the retrospective method, prospective methods, and laboratory determinants. So retrospective is in the past. So what led to what is happening now? Prospective is the future. Their possible outcomes, what might happen later on if they continue this level of use. Laboratories such as UAs, breathalyzers, swabs, all determined by time and specific factors. So looking at swabs, most of them only work for maybe the past 48 to 72 hours. And of course, that goes very well with some of the substances that are used out there. So signs and symptoms of alcohol and or drug use these make up the DSM-5 criteria. Self-report questionnaires can also be used. So during the assessment, client comes in and said they've had a glass of beer or a bottle of beer, whatever it might be. Maybe they've had some liquor or wine, depending upon their choice. But remember that amounts do matter. One drink does not is not a large bottle or what some might be called a man can or a glass of liquor. So remember, the amounts do matter. Whether if they have a glass and it comes out that each glass is like 4 or 5 shots, then you definitely need to be able to count the shot, every shot, as a drink. So, looking at the contents of problem assessment, the consequences of alcohol and/or drug use. So, looking at those, we have the Michigan Alcoholism Screening Test. The Drug Abuse Screening Test is a DAST, now called the Drug Use Questionnaire. Alcohol Use Inventory, Alcohol Use Disorder Identification Test, and Addiction Severity Index. So, looking at that, depending upon which master you're using, because there's one with a 12 or 22 questions, there's a short version, a long version. So those are within the past 12 months. The Alcohol Use Disorder Identification Test is a 10-item questionnaire, and the Drug Abuse Screening Test, the DAST, is a 20-question. Okay, so contents of a personal assessment examines problems to determine if they are attributable to the use. Looking at their medical status. So sometimes maybe they might have a lack of memory, so you need to be able to figure out whether this is something that is a medical problem or an alcohol problem. Sometimes what might come out and be able to figure that out is how fast it has happened. So usually with alcohol, it can happen very quickly, or quickly over, compared to such things as like Alzheimer's or something. Psychiatric status, looking at this mental health. So if they're having hallucinations, delusions, you'll be able to look at whether these have occurred before the use or only when they're using. Vocational issues, personal problems, sexual problems, social support, family structure, need for recovery support. One thing I'd like to bring up is that with the psychiatric status, what might need to be with some of these things is also looking at cultural issues, because there has been cases where natives will have special gifts or something maybe they're not aware of yet. So remembering to look at whether they also have an ancestry with, like, they had medicine people within their family background. So these could also be a cultural thing that's emerging. Okay, contents of a personal assessment. Use of their leisure time. What are they doing? Are they exercising? Look at the demographics, whether what is going on within their family, where they come from, what are the population size, where they grew up, looking at their family history, prior treatment history, their intelligence, their cognitive function, their personality, their treatment goals, or if they have goals, social stability, situational factors, whether they right now are in between housing or in between work, their spirituality. Now, normally what happens when natives begin to use, they back away from their spirituality. And normally that's out of respect, because many of these, if they're using, they're not allowed to be able to participate in ceremonies or things like that. Well, over time, what happens is people that have once seen them in these ceremonies or something will ask, "Hey, where you been?" I said, "Oh, I've just been busy." So later on, they want to stay away from all of them. So they begin to even go back further, and then finally it's like the family begins to ask. So then they start to isolate themselves, which also causes um, isolation, of course, grief, and all the things they've lost. So, for instance, if they felt very good about themselves, maybe they had a high self-esteem, maybe they were very um, they felt really good about their spirituality and the ceremonies and things that they participated in, but when they began to back out, they begin to lose these things. Okay, so looking at the overview of assessment process, um, so detection, of course, is and then detecting what they're using, the classifications, functional assessment, functional analysis, treatment planning, and recovery capital. So it's the action or process of classifying something according to shared qualities or characteristics. So classifying, grouping, ranking. Um, so then while you are doing this for a treatment plan, um, you want to look at these things that seem to be maybe classified or ranked very high. Begin to look at those things first, because those are the things that the client really needs to be able to look at right away. So many of these things may be put in the treatment plan. The resources you might use, looking at the social, the physical, human, and cultural, spiritual, which are necessary to begin and maintain recovery. But so looking at the treatment plan, you want to be able to find out what their plans are. If they have goals, do they want to get back into the ceremonial or the spiritual type groups? And if so, then it'd be good for them to reach out to them and to be able to get started with that. Okay, so detection. Um, Looking at some of the things you might be looking at is, are they shaking? Are they having difficulty concentrating? Um, Looking at this, if a client comes off of alcohol, they may feel very alert, kind of hyper. While substances such as meth, they may be tired. Because normally when a client is coming off of a certain substance, it's the withdrawal symptoms are actually the opposite. So also, can you smell any substances? If so, then you need to be able to figure out if they're using at the time or on a substance, and you may need to reschedule that. Okay, so looking at the classifications, assess possible DSM diagnoses, rate the worst period of use, utilize multiple sources of information if you can. Remember, though, you're going to have to get a release of information from the client if you're going to do that. The worst period of use, maybe it's when they were really down on their luck. Maybe there was something going on in their family or something that had occurred. Okay, looking at the functional assessment is obtain the client information, use all available sources, assess the client's range of different needs. So are they able to get into the substance treatment? Are they able to make that? Do they need transportation? Do they need child care or something like that? Identify the client's strengths. A lot of times the strengths might be something to be able to use to help them remain on track, because these are something with goals that they want to work on. Identify the client's support system. Do they have family or people around them who care and who can help them through this process? Identify the client's recovery capital. So remember, culture is seen as a strength, and it's also a prevention tool. That's something that is is really coming out is prevention culture is very important. Okay, so the functional analysis, um, identify factors that maintain substance abuse. So looking at their family, friends, home environment, leisure. Um, are they watching football games with their friends, or had they been using while they are watching football games or baseball games, whatever it might be? Because the games itself may become attributed with use, so they may begin to have cravings during those times, and those are times when they might need some kind of relapse um, warning things, or you know, look at relapse warning tools, or but also something to help them coping mechanisms. Explore their possible motives. Identify motives and costs of working hypothesis, not facts. So depression. Okay, look at depression. So alcohol is a depressant. So is it actually making matters worse? Has there been recent breakups, divorce, loss of loved ones? Reliance upon a crutch or coping tool like this may lead to consequences. So those are, maybe they're relying upon the use to be able to help them through that. But remember, this can also lead to more problems with the use. Okay, so one thing to look at that back part is looking at what maintains a use. So if they're using during certain kind of, oh, sometimes, I don't know if you've ever heard of, like, people been to powwows. Well, a lot of times at different powwows or around there somewhere else, they might actually run into people, and they might be having a large party or something like that. So a lot of times what they call those is a 49. So a lot of these are partying out there. So also look at powwows could also be a danger as well. I mean, a lot of people look at that as something they put on their treatment plan. I'm going to go to more powwows, but you also remember that there can be a little bit difficulty with that. Okay, so methods of obtaining assessment information. Let me see. Okay, so there's face-to-face interviewing, semi-structured interview, and structured interview, paper and pencil tests, computerized assessments. So the face-to-face allows for the use of micro-counseling skills. We need to be able to also see their body language, their posture. Are they crossing their arms? Are they rocking back and forth during certain times? Are they sitting up straight? Sitting up straight, looking at the counselor. They could have, they could be sure of themselves. They have confidence in themselves. The gestures. Look at their hands. How are they expressing those? Facial expressions. Do they have signs of anger or fear? Look at the eye movements as well. But also remember that with the Native community, the members and stuff may not always look at you in the face. They may not always look at you in the eyes. A lot of times this can be out of respect depending upon your age. It does have some cultural implications here. So remember to look at that. I've seen counselors before that said, oh, these clients aren't paying attention. They won't even look at me. They're just scribbling on their paper or something like that. But normally what happens is they realize if they were asked a question, the client is able to let them know that they have been listening, and they can even comment about what is being spoken. So looking at the assessment tools, so a little bit further into addiction severity index, the semi-structured interview process. So the ASI has been really common within the native tribes. So within their computer programs, we're able to get right on there and go right through there. It has culture added right in there. They have the medical status, employment and support, drug use, alcohol use, legal, family, social, psychiatric status. Goes into a little bit more of the history, the current use of drinking problems and related manners, consumptions, and problematic behaviors. So the ASI, which many of the natives programs are using, they do gather a lot of information as well as what tribe are they from, or what clan, or different kind of information depending upon what you're utilizing. So, let me see. Okay, so looking at what is called the timeline follow back. So you need to be able to analyze and put forth, I guess, the patterns, the intensity of uses, the frequency. Is it only happening on weekends? Is it once a month? Or is it only on holidays? So a lot of times there might be a connection between the use and significant events that have been established. So is this a time in the past when somebody has passed away in their family? Is this something that has happened that has been affecting them over many years? So you need to look at some of those things. But also to be able to kind of read between the lines, it's like you see a lot of, like for instance, if there's a client comes in presenting, I use, but when I do, I feel really good. It all goes away. I don't think about it anymore. But later on in the assessment, it comes out as like, do you ever feel sad or sadness? Do you cry when you use? Well, sometimes, yeah. I mean, I cry because I remember these people. So really, those two kind of comments they have made don't always match up. So we need to look at that and figure out what that is. Okay, so assess the situation of heavy drinking. Examines 8 categories. So negative emotional states, urges and temptations, negative physical states, interpersonal conflict, personal emotion states, social pressures to drink, testing personal control, and positive social situations. So looking at even social pressure to drink. So looking at friends, are they kind of pushing them? Oh, come on, don't be a wuss. Be one of the guys. You should do it all the time. Things like that. It's like, oh, this will be the only, this will be the last time. But sometimes you need to be able to remember to remind the client is like, well, how many last times did they have? So a lot of times they need to be able to kind of have things planned out and what they're going to be able to say. That is something that is really helpful. That way they don't have to think about it on the spot. Give them something that they could use. So in negative emotional states, are they sad when they use? Urges and temptations. Are they, during these times, do they have cravings? Positive social situations. So if they are using, and when they're using, they are more outgoing when normally they're very shy. Those kind of things might actually get them to use more as well, because they're finding themselves that they are feeling better and strongly about themselves, higher about themselves. So look at those. Sometimes those can also be a danger. So self-report instruments. Client imagine themselves in each situation, rate on a scale of 0 to 100. 0 is not confident, to 100 is very confident. How likely will they be able to resist the urges to use heavily in that situation? So a lot of times, if this is the case, we definitely need to prepare the client beforehand to help them through that process so they don't have to think about it on the spot like I was saying before. Also build in coping mechanisms. These are, if they're not very confident that they can control themselves, at that point they probably aren't ready for that, and to back away from those kind of situations or areas that might be leading to that. Okay, so substance abuse subtle screening inventory, the SASE. So one page self-report screening. It has a resistance to faking, identifies individuals in denial or deliberately trying to conceal chemical dependence. So sometimes within these questions, there are kind of questions built in there to whether they are actually telling the truth or not. You know, depending on how you've been taught about it, there are things within there that helps to be able to tell um, how there's like even kind of emotional states and stuff like that. A lot of times these levels, whether high or low, or too high ones or too low ones, can actually signify different things that need to be looked at. Okay, so the 8 core, okay, a global appraisal of individual needs, again. So we're looking at 8 core sections. We're looking at the background, the use, their health, their risk factors or behaviors, their mental health, the environment, legal, and vocational. Okay. Then we get into the DSM-5, which, okay, DSM-5 chapter on substance-related and addictive disorders includes 10 substance-related disorders. Now, remember that with the DSM-5, that other is a gambling disorder. Okay, up to this point with assessment, I guess, are there any questions? Okay. Okay, so Wilson DeVore um, talks about the assessment tools. And he says the assessment tools are interesting when it comes to the Navajo language, as most of our daily positions of speech is in the second person, he, she, her, etc. And sometimes this can be perceived as denial. So yes, it's I think sometimes when we that's something similar to other tribes. I think a lot of times if the client doesn't look at them or they're speaking in certain terms, of course, from other cultures and the way that they've learned is that it can be something with denial. Even, looking at the eyes or something like that can be very difficult. Um, Remember that there's a lot of different cultural factors that come into play. Remember, though, a lot of these different assessment processes, even such like the DSM-5 and different mental health exams, many of these testings were not really studied with natives. Maybe even looking at the Minnesota, the MMPI. So a lot of times they found out later on that natives tended to score high within that. Because a lot of times when they tested these, the native community or the native members were not part of that study. Anyway, it looks like we might have another question or something coming in. Okay, yeah, then he goes on to struggle. So the struggle then becomes a system triangulating to establish first person response. I. Yeah, I think sometimes the in trying to focus on one thing within an assessment or a counseling session or something like that, sometimes it can take off track of what is actually going on within the session itself. Okay, so now let's go on to substance-related disorders in the DSM-5. So you look at substance use disorders. Almost all the substance-related disorders in DSM-5 include either substance use disorder, intoxication, or withdrawal. So almost all the specifier of a substance use disorder will be either rated mild, moderate, or severe. Exceptions include caffeine, hallucinogens, inhalants, and tobacco. So a lot of times it's like with tobacco or caffeine, it has to do with how it's seen within the communities, how it's seen in the general population. Hallucinogens, they don't really consider intoxication or withdrawal, just like inhalants. I mean, inhalant is not an intoxication either, because what it's doing is actually affecting the brain. It's blocking oxygen from getting to the brain. So sorry. So then they've said that there is no intoxication at all. So tobacco use disorder, they say there's no intoxication. I believe that in some of these there are some kind of let's see, what is Meritil inhalants destroy the neurons. Yes. I mean inhalants. I've seen people who kind of mimic what is it? Some of the diseases that affect the muscles and destroy those. It's can look very debilitating. I mean, although with that case there, over time when they stopped using it, actually they became normal again. Okay, Mary Till says the chronic inhalant abusers will have permanent cognitive decline. Mm-hmm. Yeah, I've seen a client like that. He was actually at one time the valedictorian of his class. Had all these monies and stuff to go to just about any college he wanted to. But then he began to use inhalants. It's very sad. Okay, so with alcohol use disorder in DSM-5, there's also alcohol-related disorder. Okay, so then they have alcohol use disorders, alcohol intoxication, or other alcohol-related disorders. Remember that these are going to have mild, moderate, or severe. The distinction between alcohol abuse and dependence has been eliminated from the DSM-5. Although abuse is a little bit different, because if they're abusing a certain substance, of course, but it's not within the diagnosis itself. Okay, so looking at mild, moderate, or severe, so to build a, let me see, so 2 to 3 symptoms they're present are mild. Moderate alcohol use disorder is 4 to 5 symptoms. Severe is 6 or more. So looking at one symptom, They won't have any kind of use disorder. But one thing that I won't get into that. Okay. Okay, so a mild use disorder reflects presence, okay, 2 to 3 symptoms. Okay, so alcohol use disorder. Alcohol use disorder is problematic pattern of alcohol use leading to clinically significant impairment or distress, as manifested by at least 2 of 11 listed symptoms occurring within a 12-month period. It's pretty similar to the DSM-4. A lot of these, if you look at some of the way that these are writing with the symptoms, you'll see that these are very close to the DSM-4s. So often taking alcohol in larger amounts or over a longer period than intended. Persistent desire, unsuccessful efforts to cut down. Spending a great deal of time in activities necessary to obtain alcohol use or recover from its effects. Cravings. Cravings is actually a new one. It's a strong desire or urge to use. So recurrent alcohol use resulting in failure to fulfill major role obligations at work, school, or family or home. So you'll see that with 5 is very common with DSM-4, although craving is a new one. Continued use of alcohol despite having persistent recurrent social interpersonal problems caused or exacerbated by the effects. Important social, occupational, recreational activities are given up or reduced. Recurrent alcohol use in situations which it is physically hazardous. So alcohol use is continued despite knowledge of having a persistent or recurrent physical or such psychological problem that is likely to have been exacerbated by the use. So tolerance, need for markedly increased amounts of alcohol to achieve intoxication or desired effects. 11, markedly diminished effects with continued use of the same amount of alcohol. Withdrawal is characteristic withdrawal syndrome for alcohol. Alcohol or a closely related substance such as benzodiazepines is taken to relieve or avoid withdrawal symptoms. So also with the course specifiers, there's also the whether they're in remission, so they have full remission or partial remission, sustained full remission or sustained partial remission. Okay, then we get into the recovery-oriented systems of care. Now, the recovery-oriented systems of care seems to work very well with natives because they're able to utilize some of the client's environment, whether they be it's very similar to like either tribal wellness courts or tribal healing to wellness courts. So recovery-oriented systems of care shifts the questions from how do we get the client into treatment and how do we support the process of recovery within the person's environment. So a lot of times we might be able to utilize what's in their environment, whether they have healers or ceremonies, different programs within the tribe that will be able to help them. Of course, remember confidentiality. So I think it's pretty similar to some of the treatment plans that was able to be utilized before, whether if they have healers or medicine people they're trying to learn from. Be able to get them within their treatment plan. They go out and look for somebody and find somebody who can help them with that. If it's somebody who's trying to get more into the culture, they've been away from the culture for a while, is to find an elder or something like that, they can help them through that process. So Treatment agencies are considered one of many resources for the client. No one source is more important than another. The various support systems need to work together very closely with the clients. So this might also be utilized family members, people that the person may look up to help them on that process. So a lot of like positive reinforcement and stuff. Really helpful. So looking at this, you take the individual, go a little bit further out into the family and community. So, and with this, we're looking at wellness. Are there places within the tribe or agencies where they have something where they can get exercise or something for nutrition? Health, of course, will include the clinic. There might be other health agencies within the tribe or something that has, I think some of the areas of the United States have medicine people or healers that are working within the agencies to be able to help them, normally in clinics or something like that, behavioral health. So ROSC support person-centered and self-directed approach to care that build on the personal responsibility, the strength and resilience of individuals, families, communities to achieve health, wellness, and recovery from substance-related disorders. So looking at that, then it goes out a little bit further. Let me see if I can get it this way. No, okay. So it doesn't, in some of the slides we had before, it goes out a little bit further over time, but offers a comprehensive menu of services and supports that can be utilized. So if you're looking at a client or patient who needs services, maybe they need child care. So then it goes out a little bit further into how do they obtain that child care, whether they go to a family services or some kind of child care place. Are they looking to get into education? Do they want to fulfill an education goal that they had? So looking at a higher education program within the tribe that can help them get into college or vocational place. Housing, do they need transportation or housing? Is there a local place that will help them get that transportation? So spiritual, you might be able to go to healers, medicine people, spiritual people, or elders within the community to help them get that. So it goes on a little bit further over time to be able to help them. PTSD, mental health, is there something out there for veterans or something like that to be able to help them, depending on what they need? Okay, so recovery-oriented systems of care is a personal-centered and self-directed care, building on strengths and resilience within the patient, involving families and communities to take responsibility for their health, wellness, and recovery from mental illness. Offers comprehensive menu of services that can be adjusted to meet the needs of the client, and adjustable to the client's pace and recovery process. Within tribal healing, the wellness course, it goes into a longer process because they feel the longer is better. I mean, many times before, it's like we're always told that treatment needs to be longer. Normally, maybe a year to 2 years of treatment. So, but that includes aftercare and stuff over time to be able to slowly ease them into the community. I for one prefer a longer treatment process, but I also kind of push for places where they can get care over time, even longer than that. Get a housing, get jobs. I think that the longer this process is going, the better they're able to keep on track. Okay, so recovery-oriented systems care encompass and coordinate operations of multiple systems, providing a responsive, outcome-driven approaches to care. Require an ongoing process of systems improvement that incorporates the experience of those in recovery and their families. Affect our involvement in the assessment process. Client is an equal partner in the assessment process. So remember that with the treatment plan anyway, The client is also supposed to be able to have a say and have equal partnership within the in that treatment plan. So, elements of recovery systems of care: we have person-centered, they're individualized, much like a treatment plan, responsive to culture and personal belief systems, they're community-based, commitment to peer services, involvement of family and other allies, and ongoing monitoring and outreach. One thing that might be able to be helpful too is the use of probation officers. I actually really like probation officers to be involved if possible. They're cost effective, outcome oriented, integration of services resulting in no duplication of services, competency based. Looking at that, that's like competency based. So then a lot of these services that cannot be held within the treatment program can be, we are able to utilize people who have more experience within there, like such as culture. Effective use of collaborators and partners, system-wide education and training, continuum of care, research-based, and flexible funding. So, up to that point, are there any questions? Usually I stop here for questions in case we are running out of time. One thing about the ASAM, I'll start out if you're going to have any questions, I can wait a little bit and talk a little bit about the ASAM during that, is that many times with tribal agencies, as long as the client is not going outside the tribe, an ASAM isn't always needed. It's normally utilized for those who are being referred outside the tribe. Okay, I think we're going to may need to rush through this part. There's no questions. Okay, so they have early intervention outpatient treatment or intensive outpatient treatment, partial hospitalization, residential or inpatient treatments, whether they are low intensity, medium intensity, or high intensity, medically monitored intensive inpatient treatment. So depending on what level of care the client is in need of, those are able to be placements for them. Remember, like the codes and stuff that come out of the ASAM and stuff, and what those levels are will kind of designate the funding and stuff that is able to be utilized for that in insurance. So dimension 1 is acute intoxication or withdrawal. So biomedical conditions is 2, 3, emotional, behavioral, cognitive conditions. Are they ready to change? Relapse or continued use or continued problem potential and recovery living environment. So acute intoxication or withdrawal. Is this something that's needed right away? If so, they might need detox. So biomedical conditions and implications. Are they going to be able to need some kind of medication to be able to help them? Emotional, behavior, cognitive conditions. Are they going to be able to need some mental health care or something like that within their treatment? The readiness to change. I think that a lot of times when the client is seeking that on their own, if they're not on probation or something like that, or court ordered, a lot of times they tend to be ready to change. Looking at the relapse. So if they are going to be relapsing a lot, they might not be suitable for outpatient. And the recovery living environments. Do they have a home where there's people using something that's going to be able to get them to use more? So one-on-one counseling and education programs. Patients do not meet criteria for substance-related disorder. Problem in dimensions 1, 2, or 3, they're stable. So in 1, 2, or 3, if they're stable, they can utilize one-on-one counseling and education programs. So therapies might include individual group counseling, motivational enhancement, opioid substitution therapy, family therapy, educational groups, outpatient or occupational and or recreational therapy, psychotherapy, and other therapies. So that's the level of care level 1. So level 1, outpatient. In dimension 1, there's no withdrawal signs or symptoms, no biomedical concerns. So dimension 3, they either have A or B, N, C, and D. So A is no occurring mental health disorder. Symptoms are mildly stable. They will have a mental status that doesn't interfere with understanding and participation. And D, no risk of harm to others. So in dimension 4 would be A and B, or N, C, or D. So they have a willingness to comply with treatment, and they acknowledge substance use and want help. So it'd be one or other C and D. C or D. So dimension 6 is A or B or C, so it would meet in one of these. So maybe they have family support, but they need intervention to improve chances of success. So level 2, intensive outpatient, is with no withdrawal. They're stable, will not interfere with treatment. So within this, they were going to have dimension 3 in either A or B, and dimension 4 A or B. So maybe they have diagnosed emotional behavior or cognitive disorder that requires monitoring, but they also need structure to be able to help them through that. Okay, so dimension 5, symptoms intensifying and function deteriorating at a lower level of care. So, of course, with dimension A or B, the current environment makes recovery unlikely. So they need to be able to be moved to a higher level of care. So clinical evaluation, assessment summary, looking at the assessment process. Let me see here. Okay, I think that there is the end of the clinical evaluation assessment. The ASAM is kind of small right now, but I think we do also have another training that gets a little bit more into detail with that. So those are examples to be able to help, especially like newer people working with the ASAM. Okay, so are there any questions? If not, Kate might have something. Okay, well, if there's no questions, I really thank you for listening in today. Okay, oh, it looks like we're going to have a question. Okay. All right. Thank you very much. Looks like it was just saying thank you for the presentation and that they're utilizing it within the treatment planning. It's great. It's really good to use, so it's good to have experience with it. Even if your tribe or something doesn't use them, it's good to know.
Wonderful. Well, thank you so much to everyone for joining us. And I'll just remind everyone before we finish up that we'll be sending out follow-up emails to everyone who attended. It'll include the link to the recording if you want to view this again, um, or to share it with your colleagues. You'll also get linked to our survey as we close out, and we'll send that link in case you don't make it there as we finish up here. But then we'll also be sending CEU request forms, so if you do want to earn CEUs for attending this today, you can do that. So Sean, did you have anything else you wanted to say before we finish up?
I don't think so. Thank you for being here. Thank you for the comments.
Wonderful. Thanks again, and thanks to Sean for sharing his experience with us. And we hope you have a great day and join us next time.